Good afternoon. I know it's a minute or two before we're starting, and we'll give folks a few more minutes to log on. I wanted everybody to get an opportunity to participate in this particular talk. But before we do that, personal thing. I know there's a lot of discussion out there about people not getting vaccinated for the COVID infection. And we're going to talk about COVID a little bit more during the course of this talk. But I'm here to tell you guys, of all the reading I've done and the research I've done, and several physician buddies I have who are intimately involved in the research for the vaccines, all tell me get vaccinated. I don't know if any of you have family, friends, or whatever who are limiting their participation in the vaccination for whatever political reason. It makes absolutely no sense from a scientific perspective not to get vaccinated. This is a bad news disease, folks, and if you get it, and as we'll point out in a few minutes, a lot of people don't survive it. And the only way to mitigate it, not avoid it completely, is to get vaccinated. So if you have any family, friends, whatever associations there might be, encourage them in all possible and all strongest terms to get vaccinated. It is 12 o'clock. My personal message is gone. So we're going to talk about cost containment strategies for the workers' compensation adjuster. As a professional adjuster, everybody kind of falls into, I don't want to say bad habits, but complacency or things of that nature. And what we're going to talk about today is a return to the basics of the things that you can do as a workers' compensation adjuster to mitigate the expense, limit the claim, get the claim resolved as quickly as possible. Okay, there we go. I apologize. Little technical difficulties. And again, I'm not the most technically astute individual. So let's go back to a time when all the fundamentals and ground rules of cost containment were fresh in your mind and applied to every single new file. And this is pretty much what I want you to take away from this talk, is all the things that you really need to do with every new file. And I know that statistically, the number of injuries claims made in this country are down significantly. There is a thing called the Great Resignation. In May of this year, over 4 million people resigned their jobs with no place to go. In June of this year, another 2 million people took retirement. Not that they would be the workers' compensation claim that you would be seeing, but if you take 6 million people out of the economy, in addition to all those who lost their jobs because of the pandemic and other issues, then you've got a lot of folks who are not getting workers' comp injuries. And in theory, your file counts should be going down, in theory. And in some cases, it clearly is. And there's a lot of rationale, a lot of reasons for that. But what I want you to take away from this particular talk is, what should I do with every new file to mitigate those claims? Refreshing your mind what the statute in your particular jurisdiction allows. I know most of this audience is within Texas. And one of the things that we're going to talk about in a few minutes is the new presumption aspect for COVID in the workers' compensation world. I don't want to get too far ahead of myself, but take a few moments, review in your statute exactly what is required and all the things that you can do to apply the statute correctly. Reestablish the goals of each case, and we're going to instruct you on those tools available that you can use that will allow you to establish the parameters of the injury, know what is and what is not part of the reported mechanism of injury. And that's kind of a complex topic right there. And again, we'll get into the COVID aspect in a minute, and find a clinical insight as to what's going on in a quick and affordable model. If you apply these tools, you're going to find that the length of time that this claim is open shrinks remarkably. You're going to find that the treatment rendered is limited to the sequelae of the actual injury sustained. And that mitigates the cost, reduces the expense, and keeps your ultimate client, those employers, with your company. This is what you want to do. This is why you guys ultimately are in business is to take care of those people who are buying those services. So that's the purpose of this talk. And we're going to go back and forth on a few of these parameters going forward. Your initial encounter with the injured employee. You'd love to shake their hands. Obviously, more often than not, it's an email, fax, phone call, whatever the case may be. But remember, the key thing is this is not adversarial. You're there to provide a specific set of services to make sure this individual gets all care reasonably required to address the sequelae of the compensable event. So it's imperative that you start out with a cordial, friendly atmosphere, okay? And you want to maintain that level of cordiality. You do not want this to become adversarial. You don't want this to become, oh, I'm going to get an attorney or whatever, because it just adds all kinds of factors to the overall process that doesn't help anybody out. You want to simply seek all the information necessary that best serves that injured employee with respect to the compensable injury sustained. And that is a big portion of this talk. And we're going to talk about health insurance in a few moments, but you need to get that information and you need to let the injured employee know you're obtaining that information simply to be able to provide all appropriate services to that particular situation. Set expectations for the injured employee. Let them know exactly what you're there to do, what they can expect from you, and what they're going to obtain from this injury, okay? Let them know at the outset, I can do A, B, C, and D. I cannot do 1, 2, 3, and 4. There was this is an example, and this is an absolute true story, where the injured employee convinced his providing surgeon that he had a low back injury and he needed an orthopedic bed, okay? And that orthopedic bed only comes in king size, okay? But my house doesn't fit a king size bed in the bedroom, so he had to remodel the house, okay? And then because he had to remodel the house, he had to get his whole yard redone. And the treating physician actually put in a request to buy the bed, make it a king size bed, remodel the house, and redo the yard, all for treatment for a low back strain. And I know some of you out there are chuckling because you know this happened to you or you've seen that situation pop up. This is not a made-up situation. In fact, most of the humorous anecdotes I provide are true stories. I mean, nobody can write this material. But again, while it has to be cordial, you are not their friend. You're there to provide all appropriate care at every single level. You advocate for them. If that person needs a surgery, advocate that because that's why you're in business. Working on a case yesterday, lady slipped and fell down some stairs and just totally trashed out her knee. Fractured patella, fractured proximal tibia, and I think she was like 60 years old, okay? But because of the severity of the injury and her age and all the factors, she needed a total knee. And that total knee, it's a big surgery, has its own set of complications, and will establish a SIBS level impairment rating. But because your injury was that fracture of the patella and the tibial plateau, that's the treatment. And you're there to advocate for them at every appropriate level. Give them everything that they deserve, not more, everything that they deserve. You're there to assist them in achieving all treatment necessary to address the compensable injury. And that's why one of the things we're going to talk about towards the end of this presentation is establishing the compensable injury. And that's the key phrase. Again, we are not friends. As much as we like to be, we're not friends with these folks. In developing the basis for advocacy, okay, all parties concerned relative to the actual injury sustained, and you're going to hear me say that a lot, actual injury sustained. I slipped and fell, and boy, howdy, I broke my leg. Or I slipped, caught myself, and I have a little maybe strain of the muscles of my back in the face of severe facet joint disease and bone-on-bone arthritis in the back, and that's not your pathology. So again, we're going to talk about obtaining the mechanism of injury, and and all of that, but we really need to establish the extent of the compensable injury that really occurred. Establish and set realistic expectations. Will there be complete healing? Oftentimes, no. What does it mean by complete healing? If I was to buy a brand new Corvette, drive it off the lot, and put it into a tree, I've gone all of 500 feet. Okay, they take it back to the shop, they fix it, yada, yada. Is it a brand new Corvette? And the answer is no. If I were to have a low back injury and there is a specific injury and findings to support an impairment rating, DRE Roman numeral 2, for a 5% award. By definition, I've got a reasonably presumed to be permanent impairment rating of 5%. I'm no longer 100%. I'm 95% minus the difference, okay? Therefore, there will not always be complete healing. But while you're not clinicians, you do have some experience with health-related issues, and that's part of your job as an adjuster. Telling these people what a realistic expectation about healing is an important step in the process. When I was in practice as a physician assistant doing orthopedic surgery, and people come in and they want to know, will I be as good as new? No. What's that old joke? Doctor, will I be able to play the piano again? You should be able to. Wow, I couldn't play before. That's not the point. The point is you may not be able to play the piano again. You may not be able to play softball again. There may or may not be complete healing. Some injuries, yes, some injuries, no. But in your experience, you need to tell them what a realistic expectation of what's going to happen should be. What is the comp process? Again, there are so many people who believe that the workers' compensation process is like hitting that scratch-off lottery ticket. Oh, I won all this dough, or I'm going to be entitled to all this dough. Here in the Central Texas area, we have attorneys who advertise on television all the time, and they convince people that if you have a workers' comp injury, you're going to get enormous amounts of money. We know that's not the case, okay? So tell them up front, spend a couple of minutes outlining the workers' compensation process and what a realistic outcome is. And that if you take that contention out of the system and develop that relationship, that cordial relationship, that will add and really save you a lot relative to the claim, what the outcomes will be. Excuse me. Again, not from a clinical perspective, you're not clinicians, but what, from your experience as a professional adjuster, what the outcomes might be. And this is how to start the process to get all the best services to all the parties concerned. And this includes the employer. He has to take care of that injured worker because he's responsible for that particular pathology. To the employee, because they're entitled to all care reasonably required to address the sequelae of the compensable event. And to you as the adjuster, you need to do all the things necessary, and you want to get that file wrapped up and off your desk. Why? Because you know there's more coming. May not be as many as a year ago or 2 years ago, but there is always more files coming. So let's start the file right. Outline to the injured employee how this claim / file will go. Note the expectations placed on you. Tell them, I have to do 1, 2, 3, 4, and 5. You're the injured employee. You have to do certain things. Take your medication. Show up for your follow-up appointments. Show up for physical therapy. Do the home exercise protocols. Do all things necessary to get yourself better. We can get into reasons why people do or do not do that, but tell them they have a responsibility to make sure they get better for themselves. And what the employer has to do to make it happen. If the expectations are outlined to all the parties concerned, this is going to minimize all the extra tangential issues that become problematic. We all know that 80% of the problems are caused by 20% of the injured employees. A lot of folks, they bang their knee, they report the claim, they get better, you don't see them again. No lost time, medical only, all of that. And there are some people who have like, wait, was there an injury? And they cause all kinds of problems because they believe, well, my cousin got yada, 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 or my friend down the street, he tells me the whole story and they believe what's going on. They're listening to the wrong people. You're that workers' compensation professional. You're that person that can outline to them all that's necessary, what expectations are reasonable relative to the actual injury sustained. And again, from your experience, not as a clinician, you're not a clinician, how should this injury turn out? Mr. Abrams, I'm sorry, but you have a myofascial strain of your low back. You're going to get a little physical therapy, you're going to get a little bit sore. This should do reasonably well in 3 to 6 weeks, something like that. You put it in those terms, I'm going to get reasonably better within 6 weeks and not 6 months or whatever. If it's a fracture or whatever more significant pathology, you can visit the MD guidelines, type in the ICD-10 code, and they'll tell you what's the national statistical parameters for that particular injury. It could be 1 to 3 days, it could be 1 to 6 years, depending on the severity. You know, if it's a motor vehicle accident, a person has a neck injury and they're in a wheelchair, you know that's a long-term problem, and they need to know that. They understand it's bad, but that's beyond the scope of this talk. I'm talking about the more common injuries that are less severe. The anticipated outcome is not always what is expected. We know that there are some people who really believe that winning the comping, they're going to get a big pot of dough at the end of the situation. Well, as we know from the 1989 Senate Bill 1, new quote unquote new law, is that there's no more big pots of money at the end. They get impairment ratings. If they qualify for additional incomes, they get up to 401 weeks of checks, but it's no longer, oh, here, I'm going to hand you $50,000. Those days are long gone. We provide services in other jurisdictions, and that's what the attorneys go for. They want to have a $250,000 lump sum payment because they're going to scrape off their 35, 40%, whatever the situation, and the rest goes to the injured employee. And the difficulty with that is once that money goes on and they still need health care, who gets to pay for it? And I think that's one of the things that the Texas legislature was taking into consideration. People would have these big pots of money, would not save it for their future health care. I mean, people had to buy that bass boat. And if they come back to Medicaid, X number of weeks, months, years later, and the state's paying for that. So that's one of the reasons why you don't get a lump sum payment for money, and you get all care reasonably required for the lifetime. So that if I had a knee injury in 1995 and chondromalacia was part of the accepted compensable injury, chondromalacia does only one thing, and that is it gets worse. All arthritis gets worse. So if I had a chondromalacia in the mid 90s, and here it is 2021, oh, I need a total knee, and I can relate it back to that, that would be a possible your expense. It may not be your claim from obviously 25 years ago, but it's part of it, and that carrier is responsible for that total knee. So be very careful about establishing the compensable injury. And note that all the needs can be accomplished with a complete and thorough understanding of the process. And what I'm saying by that is, if you tell them everything up front and you have that cordial relationship, there is no need for legal representation. Now, fortunately in Texas, we have the ombudsman program, which mitigates that somewhat, but in other jurisdictions, attorneys are involved. In fact, 49 other jurisdictions have attorney involvement on both sides of the fence. You know, but here in Texas, the payment to the attorney comes out of the injured employee's pocket, with the exception of the ombudsman program. So that if they understand that, maybe they don't get an attorney, which attorneys can make your life that much more challenging, and we go from there. And this is not talking about attorneys. So with that, understanding that if you establish a cordial relationship, understanding that if the whole process is fully explained to that injured employee, when you do that first 3-point contact and you're talking to them, let them know what they can expect. That mitigates a lot of the problems that we see, that I see in the files that we handle for adjusters relative to medications and surgeries and all kinds of requests. With that, there are several tools that you can use to mitigate what's going forward. We talked about establishing the foundation, and now let's build on that foundation and progress to the successful conclusion. But before we do that, let's talk about the elephant in the room, COVID-19. I know that you're all familiar with the quote unquote Delta variant, and now we have the Mu variant. The bet here is, are we going to run out of letters in the Greek alphabet before the variants stop? Yeah, the answer is yes. The question is when. This virus tends to mutate frequently. And when I say frequently, I'm talking like within a month or 6 weeks. We get a handle on it and things change a little bit. And taking this electron microscope, I don't know if you can see, here's the problem right here. These little golf tee shaped little items, this is where the problems are. This is where it compromises the health of that injured individual. There are so many questions and so few answers. In medicine, we have a saying, the half-life of a medical education is 15 years. That means everything I learned 15 years ago, half of it is obsolete. As an example, I've not been in clinical practice for a little over 20 years. And at that time, I was writing non-steroidal medications for my patients, but not Celebrex. Why? Celebrex wasn't around then. I've taken Celebrex for my needs, but I've never prescribed it. It was a relatively new drug. And then we have other drugs like buprenorphine for opioid addictions and pain control. Again, these are newer drugs to answer newer problems. We talked about the vaccine a few minutes ago. Those vaccines, they're not even a year old yet. And are they losing their utility? To a degree, they are, because the virus is mutating. The idea of using the mRNA sequencing to develop vaccines in such a short time, that's been developed over the last 15 years, but the vaccine itself clearly has been only developed in the last 6-8 months or whatever the case may be. So COVID's out there, it's going to be a problem. And when we talk about Senate Bill 22 in just a moment, you're going to see how that's going to become an additional problem if you have clients who are public entities. One other aside, and I mentioned the half-life of a medical education is 15 years, and I think the exception is COVID. The half-life of the medical education is closer to like 15 days. I have done a fair amount of research in COVID because of our clients, and I help out with our physicians who do a lot of research on their own relative to COVID so that we can talk about COVID in the workers' compensation space. Articles are being published almost daily, and there's some consistency, and everybody's trying to come up with that new thing, but it changes so much, it's so difficult to keep current. What we do know, the virus continues to mutate. We had the South Africa, Brazil, UK, California, Delta, Mu, and I think there's 3 or 4 other preliminary reports of additional mutations. And we have, with the advantage of the electron microscope, which I showed you a few moments ago, we can see these mutations and we see the different findings, and there's a different testing well beyond the scope of this talk, but this virus continues to mutate on a very rapid basis. Newer strains are demonstrating an increase in contagion. What does that mean? It spreads faster. There was a case report out of a classroom in South Carolina. One kid had a sniffle, and the next day, like half of the class was down with the Delta variant. And these are young kids. Like, I think it was like at a middle school level, like, I don't recall exactly, but young kids who got really sick, and they're not even eligible for the virus. I'm sorry, eligible for the vaccine, but it does spread and it mutates and it's very contagious. You know, maybe we are on the bridge of the zombie apocalypse and World War Z. I saw that movie a few years ago. They're rerunning again. Maybe that's what's going to happen. I don't know. But there we are. With the mutated virus, you can become infected again. I think I mentioned to you in past talks, I had COVID last year. I was hospitalized for just under a week. And I was looking at my medical records from an objective eye several months after the fact. I was a sick puppy and I'm doing great. But could I get sick again? And the answer is yes. I got vaccinated within 12 hours we were listed a number of places, and come and see us tomorrow morning. I'm there. Boom, drove an hour, got vaccinated. 1 month later, drove back the hour, got vaccinated again. And as soon as I'm eligible for that booster, I'm going. And in fact, for the first time in many, many years, I'm even getting a flu vaccine just to be protected. But you need to know that if you had COVID and if you haven't vaccinated, you can get it again. And the point here is that while you may get it again, you won't be as ill. Hopefully I don't go back in the hospital. That's no fun. And we know we're going to show you some statistics in a moment, how many millions of people have passed away from this disease and how widely it's spread. But I want you to know you can be reinfected even though you've been protected. And that's not a good thing, but get the vaccination and it mitigates how sick you can get, okay? It is a particular challenge to keep current. As I mentioned, articles are coming out on a daily basis. It's really very, very difficult to keep current. I did find there is, at the Johns Hopkins University, they have a free website and you can log on and sign up for free updates. It tends to be scholarly and clinical, but I believe you as professionals understand the records you're reading and you can keep current, because if you get a COVID case as a compensable injury, you want to be able to speak intelligently to that individual. If you can talk to them with confidence, with a certain intelligence and education about the process, that's going to help them do better. They're not going to be panicking, and that makes, again, it's a cost savings tool because it'll keep things on a more even keel. But go to the Johns Hopkins website, sign up for their emails, and I get them, works out. Okay, so what does the applicable statute say? As you know, multiple jurisdictions are obtaining new legislation. Texas, in the legislative session that just ended up having 19 different pieces of legislation proposed. Only one passed, okay? That was Senate Bill 22. But other jurisdictions are looking at all kinds of presumptions and other issues relative to COVID. Really, it's very problematic and nobody really knows how to deal with it from a public health perspective. Some states don't do legislative, they do proclamation, like Florida. They just send out an edict. Yes, there was no process involved. Two senior public health officials just issued a proclamation and that's how they handled it. The question then becomes, is there a basis for presumption? Well, from a clinical perspective, I don't think so. As of September 3rd, 2021, there have been 39.5 million cases of COVID infection. Therefore, that's an ordinary disease of life clinical situation. That's not an occupational event. The total population in this country is 328.2 million people. So in September, we had 3.7 million. I'm sorry, I'm getting ahead of myself. I apologize. So we had 39.5 million people who've been infected in a population of 328 million people. So if 11% of the population has caught the disease, how is this possibly an occupational exposure? In Texas, our population has grown as per the last census, but we've had 3.7 million cases. We had almost 10% of all the cases in the country in Texas. And to say that it's presumed you got it at the workplace, as opposed to I went to Lowe's, I went to the grocery store, I went anywhere. I don't know, I have a hard time accepting that. But there are some people who just wanted to do that. Again, from an evidence-based medicine perspective, it's very difficult to say this is an occupational event, and that's why there had to be a statutory change establishing presumption. The only good news is under Senate Bill 22, it is a rebuttable presumption. Therefore, if you can come up with competent, objective, evidence-based medicine rationale establishing that this particular situation was not a function of the occupational exposure, then that presumption is rebutted. I would tell you in the last several weeks, we've had two cases. Unfortunately, both were death cases. And because of presumption, a case that was denied 6-7 months ago, they're bringing it back out and saying, oh, it's presumed under the statute that I got it on the job, and therefore the injured employee passed away, and I should be getting lifetime benefits. And if you think about it, that could be a big chunk of dough, all right? Is it yours? Well, it may be. Under presumption, we may not be able to establish to an evidence-based standard that it was not a function of the occupational event, but give yourself the opportunity to make that case. So when you get a COVID presumption case, do all your due diligence, get a hold of the right people, and try to establish, is there any basis for rebutting that presumption? Because the downside, it's incredible. I can tell you, and you probably already know this, but COVID involves lungs. Obviously, it's a pulmonary infection. Heart, you can get conduction deficits or atrial fibrillation, other things. You can get acute kidney injuries. That happens quite frequently. There are some articles out there that says COVID can be causative of diabetes. Let's think about that. Before there was a pandemic of COVID in South Texas, there was a pandemic of diabetes in the Hispanic population. Like 40% of the adult Hispanic population over age 40 had COVID. I'm sorry, had diabetes. I'm getting confused with my pandemics. Okay, all of a sudden, now you've got that same individual who gets COVID and has diabetes, and if it's presumed to be a function of the compensable event, then you're paying for all their insulin and all their complications of diabetes, and it's a whole big deal. And then there's some articles that say a variety of other medical maladies, but let's limit it to heart, lungs, and kidneys. And if that person comes back in 6 months or a year or whatever and needs a kidney transplant, what's that going to cost you? Or they need a heart transplant, or they need a lung transplant. All of that is within the realm of possible. And all of a sudden, you've got the $6 million man. You know, you're rebuilding him from, we can make him better. So before you accept COVID, do everything you can to establish to an evidence-based medicine standard that it truly is your injury. Title VI, we talked about Senate Bill 22, Section 607-0545. I'm here to tell you, as of last week, they hadn't even put this into the statute. You go into the website for the Secretary of State's office under Section 607, and it wasn't there. This was just put in there a couple of days ago. A firefighter, peace officer, emergency medical condition who contracts a disease is presumed to have it, but it may be rebutted by a preponderance of the medical evidence. Okay, so you can rebut this. In one of the cases we worked on, it was a police officer who says his family, he had passed away, unfortunately, said, oh, he got it because it's presumed to be permanent. But it turned out 5 days before he became ill, he went to a wedding, and at that wedding, over 30% of the people who attended the wedding became ill with COVID, and 3 members of his family became ill with COVID. So we established that it wasn't a function of the occupational event. In my research, I did find an article that established that by age, they can tell you how long it is before COVID becomes apparent. Excuse me. As an example, if you are 52 years old, you're exposed to COVID, you're going to be symptomatic in 4.5 days. So therefore, where it used to say 2 to 14 days, that was the original thought process for an inoculation. Now we know that if you're 55 years old, 50 to 59, if you're that age bracket, you're going to get sick in 4.5 days. If you went to a wedding 4 days ago, and on the 5th day you're sick, I could establish to an evidence-based standard that you got it at the wedding and you didn't get it because you're a firefighter, police officer, or EMS. Now, it may not always be that obvious, but give yourself the opportunity to apply the literature. So you may do that, because if you don't, do you really want to be paying for heart transplants, kidney transplants, and all of that? I don't think so. There are a number of documents who are keeping it. I'm sure you all have access to the MD guidelines and the ODG. And if you don't, give me a call, because I do. And they have frequent updates, particularly the MD guidelines. They are updating all the current literature relative to COVID as well as they know it. And it does change very, very rapidly. But with a couple of mouse clicks, you can track this down and find out what is the current thinking about COVID relative to certain situations. Okay, but it is in the MD guidelines and is in the ODG. But again, if you can keep current and to a lay standard, but a professional lay standard, but I mean, you can talk objectively and competently to the injured employee about what's going on relative to COVID. It will calm the situation down, and that's really what you want to accomplish. Then we are going to assess the file, okay? We've established rapport and a non-adversarial relationship with the injured employee. I come back to this a lot because I think that's key to most of the keeping things calm and under control relative to all the issues that we may face. The first thing you really need to do is establish the mechanism of injury. In medicine, we have a saying, common things happen commonly, rare things happen rarely. You don't slip and fall, twist your back a little bit, not hit the ground, you just kind of slipped a little bit and you grab the railing or whatever, twist your little back a little bit and have 5 lumbar disc herniations. Doesn't happen. The physics don't work out, okay? But you need to establish the mechanism of injury. Look at the one at the initial report of injury, okay? How did this injury occur? And this is a question you want to ask repeatedly throughout the length of the claim. Every time you talk with your injured employee, ask them again, because I don't know how many times you've seen it. I know I've seen it a number of times where the injury tends to get worse with the length of time from the date of injury. So I was carrying a 5-gallon water jug to put in the cement barrel. And then 6 weeks later, I was carrying a 50-gallon water jug to carry to the cement barrel. And then 8 months later, me and a friend were carrying a 500-gallon jug of water to put in the cement barrel. Wait a minute, what's going on here? If they can't be consistent with the injury, then you got to raise a red flag about the rest of the thing. So how did this specific injury occur? And you cannot be too detailed. It needs to be a part of the initial conversation you have with the injured employee, because what you really want to do after that conversation is complete, find out what he told the ambulance person if there was an ambulance evacuation involved. Find out what he told the ER doc if this person went to the emergency room, or what he told the doc in the box provider at the time of the initial clinical evaluation. Far too often we see these individuals who tend to talk to their friends or whatever, or embellish to make it happen. In my experience of working in a lot of Saturday nights in a lot of emergency rooms, when they come into the ER, they tend to tell you exactly what happened. I was in a car accident, I slipped and fell, whatever it is, because they're kind of shook up and they're afraid and they want to get treated appropriately right then. And before they had a chance to think about it and say, oh, did I win the lottery or whatever, then the stories begin to change. So you need to have this as part of your initial conversation and frequently repeat that, as we talk about in a minute. At different times, ask the same question and look for consistency. If they're not consistent, there's a red flag for you. And again, as I mentioned a moment ago, review what the injured employee told the ER doc and what was related to the first treating provider. And I see it all too often, unfortunately, that the stories change within the first couple of days, first couple of weeks, whatever. And it compels us to find out what else is he being less than candid about. Obtain your own comprehensive history. As a provider, in the emergency room, I would get that whole history before I take it in, even before we do the physical examination. What's the chief complaint? My foot hurts. Okay. How did you hurt your foot? I was walking down some steps and I slipped off a step and I hit the bottom step and I got pain in the heel of my foot. Okay, that could happen. Is there a past medical history? Well, I'm diabetic. I've got osteoarthritis and I have gout. Whoa, this guy has a compromised foot to begin with. Have you ever had any surgery? Well, I had an ankle arthroscopy a few years ago. Whoa. So you see how all this adds to it? You want to make sure that when you have that initial assessment, you get these data points in place and then compare them to what other providers have obtained or what you know to be relative to the mechanism of injury. Always ask the social history about tobacco use and alcohol use. Fortunately, in our society, we are down to less than 20% of the population consumes tobacco. It's still 20% too high, but they do. And we all know the dangers of tobacco. I'm going to date myself. I can remember watching in 1964 when the Surgeon General said tobacco is not a good thing. On the stage, and all these guys from the governmental health agencies out there, 3 of the guys were smoking. That's how bad it was. But that was our society. I would tell you, when I was in the Army, part of our C rations, we'd get a little package of 3 cigarettes. Everybody wanted to smoke. We thought that was a good thing. Okay, we now know it's not a good thing. And people do smoke, but there is a lot of tobacco being produced and consumed, and it has a deleterious effect. As an example, tobacco consumption is a specific contraindicator to a lumbar fusion surgery. If that surgeon really wants to do the surgery, he'll find ways. He may not ask the question, but he'll get in there. But if you know that person's consuming tobacco, whoa, don't do it, because you're not going to have a good outcome. Okay, I'll say you may have a good outcome. The odds are 90% against you that you will. So get your own social history and go with that. Gather and maintain all the medical records. And I know this sounds so easy from my perspective. You're getting them really a challenge, particularly the emergency room records. The hospitals aren't really forthcoming, if you will. And know that there are services to assist you in obtaining those medical records from day one. You cannot have too much information. So if you really need to see the emergency room records or the doc in the box records or whoever, because that's going to tell you the information obtained and how the case was directed. And it may show you that there are other pathology completely unrelated to the injury that's driving the need for tizanidine, or the driving the need for steroids or opioids or whatever the case may be. Get all the medical records you can get your hands on. We just talked about the emergency room records. Remember, as I mentioned earlier, when you come in the emergency room, they're still a little shook up and they're anxious and they got some pain, and they want to make sure they get everything to the doctor so they can get taken care of originally before they get a chance to figure out how to make it a worse situation. So after you complete your assessment, there's additional tools and services. One is what we call the early compensability assessment. In other jurisdictions, they call it the respondent investigation analysis. Whoa, great terms. But the point is, you want to find out not so much what the injury is, but what the injury is not. Health insurance is a very expensive proposition. In our situation, I pay on an annual basis probably 100 times more for the health insurance premium than I do for my workers' comp premium. And that's with copays and out of pockets and all those other devices relative to the health insurance world. So people want to make that injury or that pathology a compensable event. If you're a 64-year-old individual and you bang your knee on a door jamb, and your boss says, go see the doc, and the doc says you got bone-on-bone arthritis, you need a total knee, he absolutely needs a total knee. Okay, but is it because of your injury? No. If it was your 4-year-old, you would kiss it and make it better. But the doctor wants to do the surgery, and the provider really wants to take care of his patient. That's his job. There are people in his office whose job is to find a way to get it paid for. So let's make it a workers' comp injury and get that deal in there. We had one case a few years ago where a podiatrist didn't get paid for his services, and he declared it an emergency, except the guy went on vacation after seeing the patient and before the surgery was done. Hell of an emergency if you wait 10 days, okay? So you want to make sure that all that pathology that we all have as we get older, our bodies wear out, we get arthritis, we get fill in the blank, and that should be excluded from the compensable injury, okay? With an understanding of what the injury is not, then you can apply the appropriate nationally published guidelines to determine what care is reasonably required. Remember, pre-authorization cannot be based on clinical indication. Cannot be based on compensability. It has to be based on clinical indication. So if I get a request for a total knee and you've got bone-on-bone arthritis, we're going to say yes, you need a total knee. Is it because he banged his knee 2 weeks ago? No, but that's beyond the scope of the pre-authorization request. And you get a trusted clinical assessment. Obtain a clinical overview of the file. Talk to somebody who you believe in. It could be a favorite PA. It could be a nurse practitioner. It could be a physician, anybody, but get a review with a clinician who can help you establish what's going on here. Get a sense of where the case should be going from a clinical perspective. There are treatment plan parameters noted in the official disability guidelines. All of that should be on your desk, part of your notes, what's appropriate care. It's a frequent question we see in the peer reviews that we do is what's the best practices, and we're happy to lay it out for you so you know. The sooner you get that information, the sooner you get the right treatment, and the case should be resolved that much quicker. And again, I mentioned a moment ago, length of disability is as per the MD guidelines, and it's right there. It's 2 clicks, and you can find out the data. You want to establish as narrowly as possible the actual extent of injury. What occurred as a function of your event? It's as simple as that. What occurred? Because that's what you want to pay for. Well, let's see. I kind of twisted my knee, but I've got completely macerated medial meniscus, and I've got a complex tear of the posterior lateral meniscus in the face of no joint space. That's a very unhappy knee that's been unhappy for a real long time. And if there's no swelling on MRI, all that pathology is not yours. So do they need an arthroscopy or meniscectomy or a total knee? Yes, yes, and yes. Is it yours? No. And that's what I'm not saying we're not taking care of what's yours. What I'm saying is you're not supposed to take care of what is not yours. And that's the purpose of this. Huge cost savings. A record review, also known as a peer review. Okay. The care is not progressing as expected. Oh, I've got 22 sessions of physical therapy. It's not better. Let's do another 22 sessions. Wait a minute. What did Mr. Einstein say about doing the same thing over and over again and expecting a different result? Okay. So here's a record review. Get all the clinical records you have, ask all the questions you want, and get a perspective, an evidence-based medicine perspective of what's going on. Well, based on this journal article, or based on this section of the ODG, or based on the MD guidelines, whatever the case may be, not because I said so, but because it's the evidence-based medicine, get a sense of what's the most appropriate thing. Remember, this is not pre-authorization or utilization review. They have different goals and standards. This is to tell you what's mine and what's the best way to pursue. Any clinical issue can be addressed. If you have a question about it, ask the question and you'll get an answer. Impairment rating review. Now, we've been using the 4th edition of the guides for over 20 years. The good news is that most people have figured it out. Bad news is they still don't do it correctly way too often, okay? Each case will have an assessment at the time of closure, and we all know future benefits are a function of that assessment. So the question is the impairment rating correct? Is the impairment rating based on the actual injury sustained? Oh, I had a corneal abrasion, okay? People get foreign bodies in their eye, a little corneal abrasion, and they get better in 24 hours. So the guy goes to the ophthalmologist and they do a visual acuity test and he's got 2400 vision. Is that 2400 vision because he's got a cataract or he's got just bad eyes like I do? No. Corneal abrasion, all better should be 0%, but then we get a huge impairment rating for that loss of visual acuity or other things like that. So again, is the correct impairment rating calculated? Have we done it by the applicable rules and all of that? So you want to get if it's that impairment rating, and I get cases where the guy had a little finger fracture and it's an 8% impairment rating, well below that SIBS level, but wait a minute, 8% for a boo-boo? I mean, the whole finger is only worth 5%. If you had a complete amputation of your pinky finger, that's a 5% impairment rating. Give them 8%, there you go. So in summary, I know I talked a lot, talk fast, but there are clear strategies that you can pursue with each claim. And I can't emphasize enough, be professional, cordial, and not adversarial. You want to, again, you're not this person's friend, but if you maintain that professional demeanor, they're going to respond in kind. You are simply seeking all information necessary to successfully adjust the claim file. That's your job. That's what you're getting paid the big bucks for. I know I'm laughing. Okay, but that's what you need to do. Establish with the injured employee what they can expect from you. Tell them I'm going to do all these services I'm going to make sure you get all the care reasonably required, but I need from you the following, and keep a little note card on your desk. What do you expect from that injured employee? Make sure that they know you got to show up at the doctor's appointment. You got to take your medication when prescribed. You've got to do A, B, C, and D. These are what's expected for you. Or if they're cleared to return to work with restrictions, talk with the employer and make sure those restrictions can be met. Because if they can't be met, and that becomes a real situation. Oh, I didn't go back to work because my boss won't let me come back with restrictions. That's not a healthy thing. Statistically, I can tell you, if people do not go back to work within 6 months, their chances of ever returning to work are like less than 5%. Okay, we don't want that. That's just going to add a lot of cost to the overall clinical situation. So again, establish what the employee can expect from you and what you want from them. And remember, there are easy to use, relatively inexpensive tools, early compensability assessment, record or peer reviews, impairment reviews. I didn't mention contribution, but that's out there that you can employ to mitigate the expenses. And you have at your fingertips someone to answer any clinical question you have at no charge. Me, I'm happy to take your calls. If you have a question, give me a call. It'll take me a couple of minutes. We'll get the worked out, and all your questions will be answered as best as I can. I want to thank you for your time. And as always, there I am. I love that picture. I'm sorry. I got to show that one off. I apologize. Are there any questions? Bree, has anybody typed in any questions? Okay. Well, guys, thank you so much for your time. We got your information, and we'll get that out to CERCON as quickly as can. And we've got a whole series more of these talks. I hope you find them helpful, and we'll get the information out to you, and we'll see you next time. Take care.